Our next section is entitled Anti-Parkinsonian Medications and Neuroleptics. Both of these types of medications work primarily within the dopaminergic nervous system. In this section, we'll discuss dopamine pharmacology and its effect on anti-Parkinson's medications and neuroleptic medications. Let's talk briefly about Parkinson's disease. As you know, Parkinson's disease results from degeneration of dopaminergic neurons, especially in the substantia nigra and the striae. Parkinson's disease is characterized by the classic resting tremor, bradykinesia, muscular rigidity, postural instability, and masked facies. Here you can see the substantia nigra in the brainstem of a normal patient. In this patient with Parkinson's disease, the substantia nigra is significantly diminished. Dopamine is very important in Parkinson's disease. We know that dopamine is very important because we've seen that anti-dopaminergic drugs such as antipsychotic medications or neuroleptics can cause Parkinsonian-like features. The goal of Parkinson's therapy is to increase dopaminergic activity in the brain. The major drugs that we use to treat dopamine are levodopa and selegiline. Levodopa, which is a precursor to dopamine, was discovered in the 50s to be an effective treatment for Parkinson's disease. This medication is converted to dopamine by the aromatic amino acid decarboxylase enzyme, also known as AAD or dopa decarboxylase. Levodopa increases dopamine for the remaining functional neurons that are present in the basal ganglia. Levodopa is always given along with carbidopa in a combination pill called Sinemet. Carbidopa inhibits the peripheral form of the AAAD, which allows the levodopa to penetrate into the blood-brain barrier where it can be active. Carbidopa does not cross the blood-brain barrier, therefore it does not inhibit the central nervous system form of the AAAD. Here are some pathways involved with levodopa and carbidopa. Dopamine, seen here in the bottom right, is a product of dopa. Dopa decarboxylase is responsible for converting dopa into dopamine. Dopamine is also a precursor for norepinephrine and epinephrine. Again, levodopa is considered the primary first drug therapy for Parkinson's disease. Its effect, however, has been shown to decline over 5 to 10 years of therapy. The adverse effects of levodopa include dyskinesias, on and off effects, as well as psychotic symptoms. All of these are related to overactivation of dopamine. Entacapone is an inhibitor of COMT, which is an enzyme called catechol O-methyltransferase. This enzyme degrades dopamine. Used in conjunction with levodopa, it can minimize on-off effects. What these on-off effects are basically when the medication is given to the patient feels better. However, the effect wears off over time until the patient receives another dose of the medication. These can be eliminated by using entacapone. Selegiline is a selective inhibitor of MAO type B. This can be used alone or with Sinemet or levodopa. And unlike MAO type A inhibitors, these do not cause the classic tyramine interactions, which can lead to a serotonin syndrome. Other Parkinson's drugs that are available but less commonly given include bromocriptine. Bromocriptine is a dopamine receptor agonist. The reason that bromocriptine is not commonly given is because it can cause some severe side effects that are related to increased dopamine activity. And these include psychosis, hallucinations, and dyskinesias. There are some newer medications that are related to bromocriptine that include pramipexole and ropinirole. They work the same, but they have fewer side effects. Another medication that you're probably familiar with is amantadine, which is an antiviral medication. It's commonly used in Parkinson's disease. It's not clear how exactly it works, but we know that it enhances dopamine signaling. It also has antimuscarinic effects. Muscarinic blockers such as benztropine and trihexyphenidyl are able to cross the blood-brain barrier easily, and they can reduce excessive cholinergic and muscarinic activity that occurs in Parkinson's disease. The way that these work is by treating the tremor and rigidity commonly seen in patients that have Parkinson's disease. Let's talk briefly about schizophrenia. Schizophrenia can be seen as the exact opposite of Parkinson's disease. Schizophrenia is usually equated to an increase in dopaminergic signaling. There are two types of symptoms that we see in patients that have schizophrenia. The positive symptoms seen in schizophrenia include thought disorders, including paranoia, delusions, hallucinations, and bizarre behavior. The negative symptoms are the parts of the schizophrenia that include social withdrawal, flat affect, and poverty of speech. The dopamine hypothesis states that schizophrenia symptoms result from too much dopamine activity in the brain. The typical antipsychotics are the older medications that were used to treat schizophrenia. The typical antipsychotics are dopamine 2A antagonists. These medications are also able to block muscarinic receptors. They can cause atropine-like effects, including dry mouth and urinary retention. These can also block the alpha receptors, causing postural hypotension, sexual dysfunction, and sedation. The classic typical antipsychotics include two major families, the phenothiazines and the butyrophenones. In the phenothiazine category, we have chlorpromazine, also known as thorazine, thioridazine, also known as Melaril, and fluphenazine. Haloperidol in the butyrophenone family is also known as Haldol and is the most commonly given out of all of these medications. The atypical antipsychotics are a newer class of medications, including these medications: clozapine, aripiprazole, risperidone, olanzapine, Certidol, and quetiapine. These are now considered frontline or drugs of choice for the treatment of schizophrenia. They're better at treating negative symptoms, but they are associated with weight gain, except for aripiprazole. The atypical antipsychotics, as we talked about, contain these medications. When choosing a medication for a patient with schizophrenia, it's important to weigh the benefits and risks of the individual medication for the patient. There are some side effects associated with these medications. There are risks of movement disorders that are greatest with the high-potency typical agents. These are the older medications that can cause movement disorders such as Parkinsonism. The atypicals are now the first-line agents, but there are some side effects that we should talk about. For example, clozapine has been shown to be very good at treating schizophrenia, but it can cause an idiosyncratic side effect called agranulocytosis, which makes it a second-line choice compared to the other atypical antipsychotics. Atypicals also cause weight gain. These medications are available in long-acting injectable forms as well. Some important side effects that we'll talk about now include acute dystonic reactions. The acute dystonic reaction is an adverse reaction to antipsychotic medications, and this involves simply muscle spasm. And these muscle spasms can occur in any muscle group. Depending on the muscle group, these can be very dangerous. Acute dystonic reactions are considered to be a medical emergency. These usually occur early in antipsychotic treatment. Usually they're sudden onset, they're localized to a few muscles, but they can be most common in the head and neck, which is most dangerous. The oculogyric crisis associated with acute dystonia can cause the eyes to roll to one side or another. It can cause blindness. Acute dystonia of the neck can cause torticollis, meaning the neck spasms to one side or the other. It can actually cause neck injury. Laryngospasm is the most dangerous out of all of these because it can cause the patient to lose their airway. And trismus of the jaw can be very dangerous as well. Again, usually these do not cause a change in consciousness or in vital signs. The treatment for dystonic reaction is an anticholinergic medication, usually benztropine, also known as cogentin, or trihexyphenidyl. These are antimuscarinic medications and can be very sedating. We also use antihistamine medications that will have antimuscarinic effects as well, such as diphenhydramine or Benadryl. Another side effect that we see in patients that are taking antipsychotic medications is simply drug-induced Parkinsonism. This usually happens days to weeks following administration. It's more common in elderly patients, and these patients present like a patient who has Parkinson's disease. They develop bradykinesia, which means slow movements. They can have a resting tremor and cogwheeling rigidity. The treatment for this is to reduce the dose of the antipsychotic medication and to give an anticholinergic medication such as benztropine. The reason these medications cause Parkinsonism is because they decrease dopaminergic activity in the brain, similar to Parkinson's disease. Usually, Parkinsonism that's caused by antipsychotic medications is reversible. However, not all drug-induced Parkinsonism is reversible. Akathisia is another side effect that we see from antipsychotic medications. This can occur hours to days after administration. Patients that have akathisia feel restlessness. They feel like they can't sit still. Sometimes this can be confused with anxiety. The treatment for this is to reduce the dose of the antipsychotic by giving a beta blocker or benzodiazepine. Neuroleptic malignant syndrome is probably the most rare out of all of these syndromes, but it must be recognized when it's seen in these patients. These patients develop muscle rigidity and hyperthermia, as well as cardiovascular instability and altered levels of consciousness. It's a medical emergency. It's actually quite similar to malignant hyperthermia, except this is seen in patients that are taking neuroleptic medications, like the antipsychotics. This is also considered a medical emergency. We're not clear as to why this occurs, but the treatment is supportive care, meaning getting your ABC, airway, breathing, and circulation, controlled for the patient, and then giving bromocriptine as well as dantrolene. Tardive dyskinesia is another complication of antipsychotic therapy that is most dreaded because usually it is irreversible. Tardive dyskinesia causes muscular movements of the face, including facial grimaces and lip smacking. It does not change consciousness or vital signs. It's not readily reversible. The atypical antipsychotics cause tardive dyskinesia less frequency, and therefore they are more popular today. Antipsychotics can also cause insomnia, and the treatment for this generally involves sleeping medications, such as zolpidem, zaloplan, some of the newer sedative hypnotic medications, as well as benzodiazepines. It's important to remember that some patients may have difficulty falling asleep, which is initial insomnia, or middle insomnia, which is when patients wake up in the middle of the night. So certain medications are better for initial versus middle insomnia. Let's talk briefly about the typical antipsychotics. Haloperidol, also known as Haldol, is the most commonly used typical antipsychotic. It's used for psychosis, mania, and some mood disorders as well. It works by blocking the D2 receptor. It's less sedating than the other typical antipsychotics. Importantly, it's also used for Tourette's syndrome. The side effects of Haldol include dystonia, akathisia, and Parkinsonism. And the way these are treated are by concomitantly giving a benztropine or a diphenhydramine-like drug. It can also cause tardive dyskinesia, as well as QT prolongation and gynecomastia. Chlorpromazine, which is another typical antipsychotic, besides blocking the dopamine receptor, can also cause strong anticholinergic effects. It's also very commonly associated with increased prolactin secretion, resulting in gynecomastia and obstructive jaundice. Chlorpromazine is classic for also causing a QT prolongation, which can cause torsades. Thioridazine, or Mellaril, is another low-potency typical antipsychotic. It works the same way as the other typical antipsychotics. Specifically, it has been known to cause retinal deposits and also can prolong the QT interval. Let's talk briefly about the atypical antipsychotics. Out of all the atypical or the newer second-generation antipsychotics, risperidone is the most commonly prescribed. Clozapine is still considered a second-line therapy because of the agranulocytosis seen with it. These are atypical because they antagonize not only the D2 receptor, but also serotonin receptors, alpha-1 receptor, and muscarinic receptors, as well as histamine receptors. Currently, these are considered first-line drugs for schizophrenia. They do have different side effects. They cause less extrapyramidal syndromes. Those are like Parkinsonism, dystonia, and akathisia than the typical antipsychotics. But they also can cause sedation, weight gain, diabetes, as well as QT prolongation. Clozapine, as you know, can cause more side effects than the other atypical medications. Tourette's disorder is a tic disorder that's characterized by a patient having vocal tics. The prevalence is very small. We're not sure exactly how it occurs, but it's thought to be genetic. There are motor tics and vocal tics that include coprolalia, which is the utterance of obscenities. Pure Tourette's disorder is very rare. Tourette's has also been associated with ADHD, obsessive compulsive disorder, and learning disorders. This is treated usually with Haldol or haloperidol or some other neuroleptic medication. This concludes our section on anti-Parkinsonian and neuroleptic medications. Our next section will involve antidepressant medications.